Great. Welcome everyone to House Healthcare Committee. It is March 14th, the afternoon session. Hope everyone had a great, relaxing break because things are going to start getting busy. So just for committee purposes, real quick to bring you up to speed on what's happening. So this week is Friday's crossover. So anything that could potentially be taken up in the Senate this year has to pass out of this committee, even if it has to go to a money committee by Friday. And then next week, floor time will start getting longer because everyone is passing out bills. And so we'll plan on probably the morning sessions to be pretty packed in committee, and we'll play the afternoons kind of by ear. So this is a good time to stay connected to your email or check in with Claire on schedule changes. For this week, we have a couple goals. So we're going to do suicide prevention as one of our goals. I don't know what's going to come out. So if you remember, we decided we're not taking specifically 283 off the wall, because if we did, we would have to send it to the money committees, even if we struck all the language and started over. So we're going to build a committee bill based on what we hear over the next couple days. Or not, depending if we determine that there's nothing that we need to do at this point. But suicide prevention is a goal. And then tomorrow morning, we're going to take up radiologist assistance. If you remember, we talked about that during the COVID bill, and we'll vote on that on Friday. We'll also do more suicide prevention tomorrow. And then Thursday, we'll do the Ways and Means Amendment on the compacts, and we'll take up the Psych Pack compact. And then Thursday afternoon and all day Friday is pretty much open right now to see what happens with suicide prevention. We will have to squeeze in a couple things. Commerce is doing a workforce bill with some of our things in it. So we will hear from them and do a straw vote. So this is the nursing scholarships and some other things that we had, EMS training that we had wanted to put in. And then Judiciary is finishing their work on H230, which is the first suicide prevention bill. And they are making some changes. And so we'll have to hear from them and take a straw vote on that as well. So if you're going to be out Friday, let me know, because that is a day we'll be voting on a bunch of stuff. All right.
Let me know if you need me to go to Commerce, because I'm the liaison.
Oh, okay. Actually, I think we're good. I told them that we need a draft of a bill, and then we need someone to come in and explain it to us. So I forgot about that. Thank you. I appreciate that. So that's where we are. So we have Chris Allen with us, Allison with us. We have some folks online. I think I saw Nick Nichols and Caitlin Quinn, maybe. Sorry, I can't see everyone now. But we're going to assume that you all will jump in as we go. So the first thing we're going to cover today is an overview of what we're doing in the state on post-vention services. Then we'll take a break. And we have everyone continuing with us to talk about the 988 crisis line and zero suicide. What I'm hoping we do now is dive deeper into what we're doing in the state than we've done previously. So some of it may be repetitive, but again, we're going to try and get down into the weeds a little bit on what's happening to see if there's anything we feel we need to direct in policy. Okay. Chris, I'm going to turn it over to you.
Good. Good afternoon, everybody. Chris Allen, Director of Suicide Prevention for Vermont Department of Mental Health. Good to see everybody again. Just a heads up, I will be talking first on post-vention, and then Nick is going to come in as well and speak to what VDH is doing on post-vention. I think we have until right around 2.
Right. Well, actually, you're with us all afternoon. So we can schedule the time, and then we do community education later too. So we can weave it all together. Just make sure we want to give everyone a break.
That's good. Very well. So I'll be starting off, and we'll start with the FacingSuicideVT.com site. So this was created in partnership between VDH and DMH. They launched this new website and public health campaign less than a year ago. The goal of this site was to promote awareness of suicide prevention resources, reduce stigma, encourage help seeking and help giving behavior, and give a voice to Vermonters who have been affected by suicide. So this is the hub of all the resources within the state of Vermont, whether that is a family member supporting their son or a neighbor supporting, just another community member, the grocery store clerk, et cetera. And this is where I want to start with the postvention presentation, because on this website, under the Give Help tab, this is where this next page or this next slide is where you would see after the Give Help, and then there's a list of how you would give help. So this one is specifically geared towards people that have lost someone to suicide. So this is where all the postvention connection can happen. And on that, so I'll just walk you through this a little bit in terms of like what it would be like if you were wanting to give someone help and after someone died by suicide. So after clicking on that page, you would see AFSP listed as one of the main organizations that offers postvention within Vermont. Here is a list of all the programming that AFSP Vermont specifically has throughout the year. So one of their main programs is Healing Conversations, which is a peer-to-peer program that gives survivors the opportunity to speak with trained, experienced volunteers. No, you're okay. And who are also survivors of suicide loss. So this is a way for someone to offer support kind of immediately after the suicide loss. And in the past 6 months, Vermont has gotten 7 requests for a peer to reach out to them. So the Vermont chapter also collaborates with regional chapters in New Hampshire and Maine to answer these requests. So Vermont's Healing Conversations program is still very new to the Vermont chapter. We started it about like 5 years ago, and since it's all volunteer based, it takes a while for that to grow.
Can I ask a question? So what is the connection between Department of Mental Health and the American Foundation for Suicide Prevention?
Yeah, so their American Foundation for Suicide Prevention is a community organization that we just want to make sure that people are aware of. There's no, right now, there's no budget that they have from us. It's all funded from the donations that are raised through their Out of the Darkness walks that happen throughout the state, in-kind donations, and then also the national infrastructure of AFSP also provides some funding for the chapter.
Art?
Yeah, I'm wondering with this requires the bereaved folks to get a hold of them, correct?
Mm-hmm.
Okay. Is there any postvention that is automatic somehow? And that gets into a sense of how the person died, I know, but I didn't know whether there was anything we have that kicks in if they see that someone, a death that was suspicious. I don't know. Just a question.
Yeah,
Question.
it is a good question. And I'll address that a little bit further
Later,
on
okay.
in the
Yep.
presentation, but it's a tricky question because it depends on how and who knows about the suicide.
Correct.
But I'll get there.
Yeah, you sure?
Yeah.
No, fine.
And so Healing Conversations, I don't know if there were any questions about that or, okay. And then moving further down, they also host International Survivors of Suicide Loss Day which is typically hosted the Friday or Saturday before Thanksgiving. In the state of Vermont, there's 4 locations that have these survivors of suicide loss days. The one in White River Junction is geared towards veterans, service members, and their families. So they work in collaboration with the VA. And there are, for those that haven't attended one, it's a day where you have a speaker presentation, typically talking about suicide loss, how we can connect with family members, our friends. There's typically some type of like healing activity. It could be arts and crafts, or, you know, planting some type of seed in a pot. And then there's guided questions and discussion that's led by a peer that has experienced suicide loss.
I just asked about the timing. Is that because the holidays are such a hard time? Is that why you chose that before Thanksgiving? Okay,
Yeah.
I was just curious.
Yeah. So it's typically a time when people are returning home. So if a sister or a brother has lost, you know, someone from high school or a family member that's typical, and they're in high school or college, they're coming home, and it's a great way for the family to reconnect.
Okay. Thank you.
And then they also, AFSP also supports support group facilitator training. So any peer that wants to get trained in how to facilitate a support group can reach out to AFSP and get this training, start their own support group. And they also, AFSP maintains a list of the support groups that are in Vermont. So it's not required for a support group that, for a trainer that has been trained by AFSP to be listed on AFSP's site. So there's these informal groups as well that pop up. So it's hard to measure the exact impact or number of support groups. And then there's also suicide bereavement clinicians training. So if a clinician wants training specifically in how to handle and work with someone that has lost someone to suicide, that's another avenue that they can get training in. They also have a similar I've Lost Someone page on their website that offers national resources and local state resources too.
So is the Facing Suicide website, is it run by the American Foundation for Suicide Prevention? No, so can you, sorry if I missed that.
No, it's a good question. I'm glad you're clarifying. So that site is run by DMH and VDH.
Okay.
And then
Sorry.
that is, that's the hub of what all these resources are off of. So when you're on this page, it has a link directly to the AFSP site, and then it opens a new tab.
Okay, great. Thank you.
You're welcome. Any questions on AFSP or?
You put the International Survivors of Suicide Loss Day, you put those, is that publicized anywhere for, I don't know, like locally or stuff for people to, because I'm writing an email right now. I'm on the Veterans Affairs and caucus. And this is not a bad thing to have, since you said the White River one was kind of focused on veterans.
Yeah.
And veteran suicide is a major issue. I just didn't know if it was publicized.
It is. I don't know the exact way that it is publicized and marketed. Just because I don't volunteer with AFSP, but I know that they do have, when I was more involved with AFSP, they had a Facebook page, which is where they would create Facebook events. In terms of more like focused marketing of the event, I'm not certain of, but
maybe it's something your department could zing out beginning of November. I don't know, let folks know, just.
It's a great
And I'm hoping to have someone from AFSP in later this week,
Yeah,
so to help.
well, but. for
Right, but
us,
yes,
Yeah,
absolutely. Yep.
yeah, it would be a good thing, so.
Yeah, is it Terry and
Yes.
Heather? Okay.
Yeah.
Yeah, so Terry's the board chair of the Vermont chapter. And what is really exciting too is that Vermont now has a dedicated area director. Her name is Heather White. So previously, in previous years, we have had Heather as like a part-time person supporting the Vermont chapter. And now she's full-time for Vermont, so.
Yeah, good.
I just happy because I'm on the website. Am I seeing there's only 3 actual support groups? I'm coming up with St. Albans, South Burlington, and Williston.
Can you just describe which site you're on?
Oh, I went under the AFSP tab.
Mm-hmm.
And then it just lists support groups. It says find a support group.
Mm-hmm.
And I'm doing 100 miles because that's the furthest they allow you to go. 100 miles from Montpelier.
Yeah,
3.
yeah.
So there's nothing in southern Vermont or anything.
I actually get to that in just a slide or two, but yes, I do recognize that there is, so some of these support groups do have virtual options as well.
Yeah.
So I know in our previous testimony, we talked about how it's harder to capture that impact of who's attending, but I do recognize that there are 3 support groups that are on AFSP's site. And there are a few more that I am aware of, which are more informal. And also AFSP's, it's a voluntary, the facilitator of the support group would have the want or desire to be on the AFSP site. So there could be even more. AFSP does not require any facilitator that's gone through the support group training to be on the site.
Thank you.
You're welcome. Any other questions on AFSP or just in general at this point?
We're good.
Okay. Yeah, so here, Representative Black on this slide where I listed out the locations of support groups that are exclusively dedicated to survivors of suicide loss. So as you'll notice, they're mostly concentrated in the northern part of the state, and also primarily in Chittenden County as well. So the goal of these support groups is to offer mutual support, education materials, really serve as another area of connection and space to be listened and heard. These are support groups that are pretty well attended, especially the one in South Burlington. And that support group has been going on for at least 10 years. So it's well established. Yeah.
Any of these have a religious component to it? Clergy of some kind?
Certainly clergy can attend. There is, I do not know if they currently attend.
Okay.
But it is also geared towards individuals. So in order, the part of the vetting process of being a member of the support group is to have to identify as a survivor of suicide loss. So the clergy would have to identify as that and feel ready to enter that that group.
Okay. Yeah, that's wonderful.
So
Yeah.
who establishes these support groups? Are they, again, is it something under DMH, VDH, AFSP on their own?
It runs the gamut. So the one in St. Albans is run through NCSS.
Okay.
Um,
Which is a designated agency.
Correct, yeah. So Deb Babby, who is also involved with AFSP, she helped establish that group there.
It's
And
not like Department of Mental Health has a strategic plan that says we're going to have support groups in every county in Vermont or something like that.
I'm glad that you brought up strategic plan. That is part of my vision.
Great. So
Okay,
let's hold that on
yeah,
that
yeah.
because I want to hear about that. Let's work through this. And,
Yeah.
I do want to make sure we have time for that.
Yeah, so just briefly, all of these groups are facilitated by peers. Again, some meet only in person, and then others have a virtual option as well. And then this speaks to your question, Art, a little bit about after a suicide, is there an automatic contact? Every designated agency can offer interventions and supports immediately following a suicide. And it really, this is where it gets a little tricky because it's all about how that's accessed. And so as this slide outlines, when someone's made aware of a suicide, the DA can actively outreach to the family as long as the DA is made aware of that.
okay.
So
And how does that happen? Who makes them aware? I mean,
it could, if it happened at a school, the school could reach out to the DA. Or if the individual was enrolled in community mental health supports with the DA, a friend, really anyone that's connected with that
okay.
individual
They can.
could call
Okay.
HCRS and say, hey, so-and-so has died by suicide. You may want to reach out to these individuals.
Gotcha.
Alyssa?
Yes.
What is the role of the medical examiner in this? I mean, essentially almost every suicide in the state, the medical examiner is there.
Yeah, it's a good question, and I don't know what the role is of the medical examiner is in this process. I don't know if,
Could be a good question for PDH as they work more directly with them. Right now, we don't follow postvention through the medical examiner's office. My take on that would be is lacking in immediacy because that process can take some time. And sometimes we don't have the determination for months. But it's certainly where we get, you'll hear about the information we do get through that process, which is extraordinarily valuable, but we're not using it for postvention at this time.
yeah, and so the important thing to keep in mind at this point in postvention as well is that sometimes when support is offered, the family might not be ready to receive professional support, and they may want more support that's within, like from friends or neighbors or other community members, clergy, etc. But the DA, or going back to Healing Conversations, you can reach out to AFSP at any point post suicide. There's no time limit or anything like that. Whenever
I'm being told Nick has his hand up. Nick, are you there?
Hi, everyone. I can, I do have additional information on the role of the medical examiner, so I'm happy to talk about that when it's my turn.
Great. We'll wait till it's his turn.
Oh, okay.
Please said.
Great. Moving right along. So on AFSP's website, there's also, Sarah, that it's a little bit cut off. It just says that it says education and awareness for how to support a loved one. So on AFSP's website, they list out a whole host of resources. This is one that's highlighted of 10 ways to support a loved one who has lost someone to suicide. So how are we talking about the suicide? What not to say, what to say, what to offer, etc. And then another very important part of postvention includes safe messaging. So we're back on the facingsuicidevt.com site here. And then under the resources tab, you'll notice that there's crisis prevention after suicide, et cetera. All of these tabs have various resources listed. Under media, there's information on reporting on suicide and the framework for successful messaging. And the first one here is in regards to youth and social media and how to message for that population specifically. So these resources, especially the reporting on suicide resource, is really effective at if a newspaper has written an article that a individual or even us at the department feels has not accurately shared information, like it might not include the 988 helpline, then we'll make sure that they're aware of that. And then the framework for successful messaging is there's a whole toolkit on strategy, making sure that the message is positive, has a positive narrative in order to limit contagion, which is individuals that are fantasizing. It's really youth and young adults are at high risk for contagion because developmentally they're very impressionable typically. So don't want to glorify the events, don't want to talk about the method, don't want to fantasize about how this happened, things like that. And then my last slide on postvention right now, this is the postvention findings from the Zero Suicide Designated Agency End of Year Reporting Survey. So this is all DAs that offer postvention services and what postventions they're offering and what was provided. So 100% of the DAs provided brief interventions and supports to loved ones immediately following a suicide. And then, further on down the list, maybe some of those individuals that had reached out to the DA or that had been contacted by the DA accessed a support group afterwards for suicide loss survivors.
Go ahead, Leslie.
I'm just wondering, it says 100%. What's the absolute number of that? Do you have an idea?
In terms of number of contacts that were made?
Yeah, it says brief interventions immediately follow. So how many are we talking about? Are we talking about 10? Are we talking about 5? Are we talking about that? I'm just thinking of an absolute number.
Yeah, that's a good question. And I don't know the answer right now on what that absolute number is.
So I'm going to take that one step further. And do you all collect data from the DAs or anyone else in all of these processes that can show us of the suicides that occurred in the year?
Yeah.
How many of those, how do I say this right? How many, so like the 142, I think was the number from 2021, right? So were family members or friends of 142 people we lost contacted?
Yeah.
How do we know that these postvention services are getting to those people? It's great that if a DA was notified of a suicide, that 100% did what they were supposed to do. But who are we missing?
Yeah.
Is there a way do we track any of that?
Not that I'm aware of.
We would have to survey the families who lost a loved one by suicide. And we haven't been taking that as our approach at this time. And right now, in terms of what the DAs report to us, we can tell you of those who died by suicide, how many of those were connected to a designated agency. We can't tell you in terms of a service provided to a clinician. The department doesn't get to tell what type of service that was. So it would just show up as a crisis response. So it would take surveying the
Okay.
family.
And I guess to take it one, sorry, to keep going on the line though, so it would take surveying, but I guess more importantly is what would it take for the state to connect with someone connected to each suicide? Like, is that back to your strategic plan,
Yeah.
part of your vision?
I would love to offer more postvention, especially regarding that immediacy right after. It's a very vulnerable time for a family,
Right.
and especially the friends and siblings, et cetera. Yeah, I would love to offer that immediate contact. I will also add that that funeral directors have materials on how to support or family members or that have experienced a loss to suicide.
I just wanted to clarify this chart here. So the percentage is just the DAs that actually have the capability of providing this. It's not that they're actually providing it. Am I reading? So like 100% of the DAs do brief intervention supports, but that doesn't necessarily mean that they are doing it. Am I reading it right or am I reading this incorrectly?
Well, the line above says provided,
Let's let Chris answer.
sorry.
Yeah, I actually don't know. That's
I can help with that.
yeah.
So it's not just if you have the capacity to, so what they're saying is, in this 2022 survey, did you actually do it? Not for everyone. So, because you may not have known that 3 in your community, but not just, oh, yes, we do that, but did you do it?
You were
That clarifies.
notified and therefore you did it.
Yeah.
And so, like, when you get down to the 29%, it's saying that, yes, we actually did do a long-term follow-up.
Okay.
So otherwise you'd probably get 100. Certainly we could do a long-term.
Yeah,
Right.
well, that's what I was sort of thinking is this that they actually did provide services or that they could provide services?
Yeah.
And are these touch points here that we're reporting on, is this a requirement of DMH to the DAs to do this reporting?
This right
Yeah.
here.
Yes.
So this was from the Center for Health and Learning and
Oh, because they did the zero suicide
they
training.
the zero suicide.
And is it something they do every year or was it just a point in time?
They're required to evaluate the zero suicide implementation. So this was one way that was decided to do it, but not beholden to this way.
Okay. And is there, and I'm sorry if you're gonna get to this, you can just tell me stop asking questions. Are we going, so that was for the implementation, are they required to analyze ongoing zero suicide efforts? And you know what, that can wait till we get to zero suicide, sorry, I forgot that's coming up next. Leslie?
I'm just interested in, you're talking about loved ones and family members, but it has such ripples. And how does it get to the ripples in the DAs? Do we have a sense of that or?
So this is my experience of experiencing a suicide loss, is that it's really incumbent upon the individual to reach out and seek that support. And that is in respect to their privacy and what they feel is needed for them at that time. Now, could those services be further blanketed across the state in terms of in different settings? And I would love if everyone knew the 988 helpline.
Yeah, I'm
Right,
just
or-
thinking, yeah, my own community, there was a tragic suicide, right? And he was a prominent member and there were ripples, right? And just thinking about how to be more, how we reach more beyond just loved ones, because in a way we were all hurt by that.
Mm.
By the way. So just thinking about that.
Yeah. Thank you for sharing that.
Oh, sorry, go ahead.
Just to offer, and I think, in fact, you asking us to do this caused us to do some more research, so I guess that's how government.
How it works, right?
But one of the things we came across, we actually hid it and took it out because we thought it would be too much, but there's a whole ecological model of postvention. It shows individual, family relationships, community, then system. And there's some interesting ways, we looked at other states of how you get at those second levels. And I would say we still see the community mental health agency as a hub for that. And so, for example, if there's a suicide in a school, we provide that response in that school. And they're there for the teacher, and at the end of the day, who supported all the students through that, who can then come and sit with them. But there's other ingredients that we probably haven't pushed to yet, which is about, you know, how does that entire community wrap their arms around that family and each other? And what are some different events, activities, ways you speak, things you can do? That's other layers, and I think, I'm sure Chris would love to put that in his strategic plan.
I think it's great. I'm just really glad you're thinking about it and that I mean, I love that notion of an ecological system view of it. Yeah, thank you. Listen.
I wanted to, something you had said, regarding that, you know, it is your goal in your strategic plan to make sure that like everybody has the immediacy of support. And I'm wondering if that's actually evidence-based. I mean, just from the people I know, because I do associate with a number of people who have experienced suicide loss. It's actually not the immediacy. It's the long term. You know, you have a community that wraps their arms around you, but then they all fall away. But you had said that, and I'm wondering, is that actually evidence-based that it's important in the immediacy to offer support, or what's the research on that?
Yeah, I can't necessarily speak to the research per se at this exact time, but I would say that the immediacy from my standpoint through my experience was that I didn't know what the resources were available, right? So it's about knowing that there's someone else that knows my experience and what that loss was and knows the resources that I can be connected to. That's, yeah, so.
So your strategic plan is to make sure that everybody has resources immediately that they can then
Or at least knows about it.
knows about it and that
Yeah.
they then use whenever they
Yeah.
require it. Okay, thank you.
Yeah, because you're exactly right. Like after the suicide, it's absolute chaos. And sometimes it's 3 months later on, could be 2 years, could be 5 years that someone is now feels ready or feels like it's time to do further interventions and supports.
You have the resources to continue all that?
That's a lot where like DAs, like families could reach out to a DA and certainly reach out and see if they are able to offer support for them. That's where a lot of the community mental health system comes in, and we rely on them.
Daisy?
So Zero Suicide is a national program, right?
Mm-hmm. Yeah, it's a framework.
What
Yeah.
states are doing a good job with postvention? Does Zero Suicide provide a network of?
Not that I'm aware of. Yeah.
Well, I was just gonna say, when we did this research, we should look at Utah. Utah has an interesting postvention program. It gets at Representative Black's point about it comes with like a 30-day follow-up and then there's a program for 6 months. But where we're getting most of our information right now on postvention is our work with the Governor's Challenge. We were down in DC and meeting with all sorts of states, and it was for service members, veterans, and their families, but their postvention talked about a specific timeline of outreach. And they have a good tracking system. I mean, what they have that we don't have is data on every single person, you know, that is lost. But they are doing a really robust postvention program, and it's relying a lot on family members who have lost a service member to lead that work, because I think the other part is it's uncomfortable for a state person to just cold call a family the day after a loss. And so it's really helpful to have a person who's experienced that, so you go and driving, here's how you might do that. when we can, we try to go through a community member to say, are they interested in a call? When do you think would be a good time? So, but we're learning a lot through the VA, and I would name them probably as the leader in this.
So let's, go ahead.
Well, it's not that important, but I just want to make a comment on privacy because, you know, privacy drives a lot, but on the other hand, people might really be shy or embarrassed or not want to be that desperate person again, so that they get left behind because people want to protect their privacy. So I think there's a tension there that worries me. I'm just saying that.
I want to have time for Nick to jump on, but I want to ask one more question on this slide. So the 0%, the bottom two have 0%. So what does that mean? That schools are not outreaching when there's a suicide death, or DAs are not responding when there's a suicide death?
The follow-up or long-term outreach,
Right.
that specific one? I would have to look further at the exact measurement of what that long-term outreach time period is. But I do know that that DAs have been responding to suicides within schools.
It would be, if you can just dig a little bit more on that for us, I think that would be really helpful. We have AOE and all of you are back again with us later in the week to talk about what's happening in the schools. So that would be helpful. Nick, did you want to jump in on a couple things or?
Yeah, do you want me to, I do have some prepared slides. Do you want me to jump into those, or do you want me to just add to some of the questions that have come up with DHS?
We can do both. We're still on postvention, right?
Yes.
Okay, so let me just stop. I know you have in here community partners. Can we just skip the community partners for right now? And then we'll try and squeeze that in, and let's go to Nick. So Nick, do you have the Zoom to share? Great.
Do we have those? Do we have those?
Yes, I emailed them to you, and they should be on this now.
Right. Yeah.
This came up, thank you.
Okay. I think I'm good. Can people see my slides okay?
Yes.
Okay, great. For the record, I'm Nick Nichols. I'm a suicide prevention grant coordinator at the Vermont Department of Health. And I'm going to be talking today just about some additional activities that are happening specific to postvention that are funded through some federal grant funding that the Department of Health has. And actually, just to answer one question before I go into my slides, I can say there was a question about the role of the assistant medical examiner, and just for folks who are interested. So the Office of the Chief Medical Examiner, that sits within the Department of Health, and there are assistant medical examiners who respond to all suicides in partnership with law enforcement when there's a suicide that occurs in the community. And so those are individuals who are on site almost always when a suicide death occurs. They are not mental health clinicians, but they often are put in a position to do some kind of mental health support or trauma support. In some cases, crisis or mental health staff don't make it to the site or are not available for various reasons. And so they do the best that they can in providing some support. And in addition, they often will try and pass along our resources to the family to let them know about what is available for support. And then in some cases, they actually assist with site cleanup. And so if there's a death that occurs that needs some cleanup, they actually find themselves in some cases helping the family with that cleanup. And that's actually, I think, one of the identified needs that has come up is that we need a better system and a source of funding. And so when cleanup is needed at a site, families aren't expected to either do it themselves or pay out of pocket for someone to do that. So happy to talk more about that if folks are interested, but otherwise I'll jump into my slides.
Yeah, I would say go ahead and jump in, but I think at some point we do want to come back to that.
Okay, great. So it was actually great to, well, let me just give a little bit of background. So as folks may remember, that the Department of Health have two federal grants focused on suicide prevention that are helping us supplement the work that the Department of Mental Health is doing using a public health approach. We have a federal grant from the CDC. It's a 5-year grant focused on Vermonters ages 15 to 64. And then we also have a new grant, the Garrett Lee Smith grant, focused on youth. And as folks may remember, for our CDC grant, which we refer to as the CSP grant, or Comprehensive Suicide Prevention Grant, one of the strategies supported under that grant is to improve postvention supports and community response to suicide loss. And so this afternoon, I'm just going to talk really briefly about some of the work that's been funded and supported by that grant over this past year. So, and it was actually, it was a great segue to hear folks talk about the need for a strategic plan and to have a better understanding of exactly what exists in the state and what is needed, because that was actually the exact thing that we focused on over this past year. We felt like it was clear that there's a lot of good practice that is occurring, but there's also a lot of gaps. The information that's available and getting out is not consistent, and there's probably also some needs in terms of having more supports available. And so we asked the Center for Health and Learning to work with us to do a 6-month statewide assessment and strategic plan to try and figure out what is it that Vermont should be focusing on. And so over this past year, they completed that statewide assessment. It involved a broad set of stakeholders. We had a postvention working group, which included lost survivors, the designated agencies, first responders, the Vermont State Police Victim Services Program, as well as AFSP. We also did a bunch of key informant interviews with the Office of the Chief Medical Examiner, as well as public safety, designated agencies, among others, as well as lost survivors. And then also recognizing that the critical position that first responders are often placed in. They are often the first ones on the scene. And in some cases, if mental health support is not available, they are not only responding to that as a first responder, but also providing some support for the families. So we felt like it was especially important to hear from them. And so we also did a first responder survey and surveyed over 30 first responders to talk about their experiences going on site when there's been a suicide death, and asking them both about what else would they need to support the families that they're working with, as well as what else do they need to support themselves, because for themselves, it can be quite a traumatic experience going through that. So I think, everything that Chris talked about in terms of what exists in the state currently really is reflected in our statewide assessment. And so what I wanted to jump to really is to talk about, based on that assessment, what are the key goals and areas that this survey identified in terms of needs and what we should be doing for our strategic plan. So I'm just going to run through those really briefly. And I think a lot of them actually hit on issues that were already brought up by the committee and discussed with the Department of Mental Health. So as a state, it was really clear from the assessment that we need to consistently have an effective response, both immediately after a suicide has occurred on site, as well as the aftermath of all suicide deaths. And so people are both offered some kind of support and resources immediately when the suicide death occurs, but also recognizing that some people are not going to be ready or want to think about or receive any kind of information. It could be weeks or months afterwards. And so we want to make sure that they're provided that information, but that we also have a way to make sure that it is available and offered in the months following the suicide death. And so for Vermont, we established several different things that we think would be important for the state. One is to create a base of what are the best practices and protocols that Vermont should be using for standard postvention response and cares. And so that means, regardless of where you're in the state, everyone is clear how we should be responding, how we should be coordinating. And as part of that, as Chris talked a little bit about, having a better system of notification. And so when a suicide death occurs, and we make sure that our designated agencies and crisis response teams are notified so they can, where appropriate, come in and provide mental health support. Also developing a better system to make sure that 90 days or 6 months after the fact, there's a way that people are becoming aware of the different kinds of supports and services that are available. Just as an example, I think last month through our Facing Suicide VT site, I actually received an email from a suicide loss survivor who sort of said, it's been a year since my loved one died. And I don't know where to look. I don't know where to find services. And so making sure that we're doing a good job promoting and sharing information about what's available, not just in the immediate aftermath, but in the months to come. It was also clear that we need to have increased support for schools and to help schools have more of a proactive post-vention plan. Unfortunately, in some cases, because schools are so busy, they're not necessarily coming up with plans or having a clear process to think about how do we respond, how do we support our students when there's a suicide death. And so doing more to support schools coming up with clear post-vention plans is really important. And then lastly, it was really clear that there isn't consistent and sustainable funding across the board to support things like crisis teams, providing post-vention support to families who may not be a client of a designated agency, or to a school, to an organization, because in some cases, they're not set up necessarily to bill an entity or an individual for providing those services. And so we need a better funding stream to make sure that they have that capacity to be able to do that. I mentioned before, having dedicated funding to help with site cleanup is incredibly important. And then, a lot of these support groups and other bereavement services are offered by volunteers. And so having more dedicated funding streams to make sure that those supports are available is really important. And just jump in and let me know if you want me to stop. Otherwise, I'm going to just keep going because we actually have 5 goals as part of this strategic plan. Okay. So the other thing that we found is that there's a lot of resource packets and informational content that's been created specifically for suicide loss survivors, but in some cases, different versions of those information are in the hands of different people. Some of it's not necessarily updated, and in some cases, some of our first responders or other programs lost the copy that was given to them 2 years ago, or they don't know who to reach out to get an updated copy. And so one of the things as part of this is we identified it's really important that across the board statewide, we have a core set of educational material that all of our first responders have in their hands and are constantly getting access to so they can make it available to family members when this occurs. Because they don't really think about it until there's a suicide death. And then they think, oh gosh, I remember getting this 6 months ago. So that's really important. And then on top of that, first responders also said that they themselves need more resources and education on how they can better understand how to support people when they're on site. And so we felt like it would be really important to create additional resource packets for first responders as well as crisis teams and other professionals on how to better support people who have lost someone to suicide. In terms of communication, it was clear that Vermont needs to be doing a better job communicating information about the impact of suicide loss and the availability of services. I think, a couple of people have raised that question of like, well, how do people find services or how do they know things that are going on? And so as part of this plan, we identified it's really important that we have a proactive plan to do outreach and advertising and promote post-vention support services on a regular basis. So people are aware of them and hearing about them on an ongoing basis. And then also, as was talked about before, doing more to connect with the media to make sure that they're using best practice guidelines when they're talking about a suicide death in ways that are not going to create additional problems. We also identified that there's lots of examples of best practice training that's out there, specifically for service providers, but it's kind of offered in a haphazard way. And then we don't have a consistent plan to make sure that our first responders and service providers and crisis workers are getting regular training on evidence-based approaches to providing post-vention. And so as a state, we need to be sponsoring post-vention training statewide and making sure that's available on a regular basis. So people are maintaining that level of skill and confidence on how to support people. And then lastly, it was clear that we need to do a better job with our surveillance systems to collect information surrounding the circumstances of a suicide death, to allow us to get more information about those circumstances and use that to inform how we're improving our services. And so, for example, Vermont actually is already in the process of implementing something called the Suicide Data Linkage Project, which is collecting
I'm sorry, Nick, we lost you for a second. Can you go back to what the Suicide Data Linkage Project is?
Yeah, sorry. There's a lot of snow on our out here, and I think it's threatening to cut me off. So,
no worries.
So fingers crossed. But anyway, yeah. So the Suicide Data Linkage Project is sort of an example of how we're trying to do a better job collecting information about the circumstances of when someone dies to understand, is there more that we can be doing to prevent suicide deaths? And so with the Suicide Data Linkage Project, we are taking a look at everyone who's died over the past 2 years and collecting service information about what kind of medical care they received. Did they receive interactions with any kind of human service provider around the state? Did they receive mental health treatment? Were they involved in the judicial system? And so it's a way to sort of collect information about where did these people appear, or what kind of services were they interacting with or receiving the 2 years prior to their death, which allows us to have a better sense of where the places where we need to be intervening or providing more supports around how we do suicide. So that's just an example of how you can actually collect more information to improve suicide prevention based on suicide deaths. So based on that, through our CDC grant, we do have a small amount of dedicated funding to implement elements of what I just talked about. And so I just wanted to really briefly share some of the priorities of what we're going to be doing over this coming year. One is, as I talked about, we need more consistent development and distribution of resource packets for lost survivors. And so there's funding through this grant to work with AFSP and the Department of Mental Health and other organizations to make sure we have a core set of resource packets, and those are available all the time, everywhere, for lost survivors to have. And then also develop a companion version of that for first responders. And so when they're out responding to a suicide death, they have that with them. So they themselves feel like they have the right set of information. We're also going to be identifying and rolling out specific training on best practices for both first responders on postvention best practices, as well as mental health clinicians. And then, as was talked about before, the way in which mental health crisis is involved in doing postvention support varies quite a bit depending on who's communicating with them, and also the degree to which first responders are communicating and coordinating with mental health crisis. And so what we'd like to do is establish some best practice guidance on how first responders should be coordinating postvention response with their DA crisis team, and set that as a standard for the entire state. And so regardless of where you're at and where you're located in the state, if there is a suicide death, first responders and mental health clinicians will have a core way of how they coordinate and support. And then we also, for this next year, we're going to be actually completing the Suicide Data Linkage Project. And that should provide us a lot of helpful information. And I look forward to sharing the information from that study when we're all back next year in legislative session. So that was a lot of information, but I'll stop there and find out if there's any questions.
Great, thank you. I have a couple. So I'm assuming that with the grant, you have to report back on what you're doing. Is that an accurate assumption?
Yeah, that's correct.
Because I'm sitting here thinking to myself, okay, this really is what our committee has talking about over the past couple of weeks, like how do we move forward with postvention and everything. And if you have to report back, that same report could come to us as well. So we know where we are as a state without having to duplicate work on your part is what I'm trying to get at.
Absolutely, yeah. And I'm happy to, I might have shared it with some of the committee members, but we have already, the statewide assessment and strategic plan That was completed at the end of this fall, and it was one of the first ways of reporting. And I'm happy to share that again with folks if they'd like to see the results of that assessment.
Yes, that would be great. And then I'm not sure if you are aware, I know Chris and Allison are coming on Wednesday. Actually, I should look to see if you're on the schedule. Wednesday afternoon, you're not on the schedule. We're taking up testimony to talk about implementing a suicide fatality review team. This is language that's in H283, which sounds similar to the suicide data linkage project, but would be for the future. So not trying to put you on the spot, because I'm not even sure if you've looked at the language in 283, if you have any comments about moving forward with the suicide fatality review team.
Yeah, well, I think you're right, Madam Chair, in that it's kind of a similar idea, but taking like the difference between the suicide data linkage project and a fatality review board. It's both are trying to do the same thing, but I think from different angles. And so I think part of it, one of the questions is, whenever you're adding on new committees or project is, will that information really help better inform what we're going to be doing? And so I think, as I said before, the suicide data linkage project should provide a mountain of new information regarding sort of everyone who has died by suicide over the past 2 years. And so I'm at this point, we're really focused on trying to see what that's going to result in before we weigh in on would a fatality review board, is there additional information that would be missing that we're not getting from the data linkage projects that would come from a fatality review board? And so I think our primary focus is let's see what we get from the suicide data linkage projects, and then determine if something like a fatality review board is needed, because we're still not getting the information that we need. So
okay.
I hope that made sense.
Go ahead, Elisa.
In the suicide data linkage project, I'm assuming you're going back and you're looking at every suicide. Is there essentially a list of questions you're answering on each of them? And if so, we have that list of questions.
I have a couple slides actually, so I'm happy. Yeah,
Okay, yes, that'd be great.
I was anticipating there might be some questions. So, Caitlin Quinn, our data analyst, actually is the lead on this, and so I welcome her to jump in if I say something that's incorrect. But basically, for the suicide data linkage project, we're going to be looking at all suicide deaths from 2020 and 2021. And we've created data sharing agreements with a broad set of providers around the state and organizations. And we're basically asking them, did this individual who died by suicide intersect with your system, with your data system? And that's going to give us a lot of information about, for instance, what kind of medical care did that person receive, or were they justice involved, or did they receive services for being housing insecure? And so it's really looking at services and what services people received. And this is a sort of a broad list of the various data, or the various organizations and data sets that we're going to be collecting from the data linkage project. And so as you sort of go through this, you'll see, some of it is specific to human services. It's sort of the various departments within the agency of human services. It's all medical billing claims. It's also our EMS data. And so if people had intersections, needed emergency medical services. As I said before, it's including the homeless management information system. We're getting great information from the Department of Labor. So lots of good information that it's going to take a while to sort through. But I think this summer a big focus of ours will be what do we make of all this information, and where are people interacting with all these various systems, and how does that inform how we should be doing our suicide prevention programming?
What about schools, Nick? So in this project, how would you be getting data on youth who've died by suicide?
I'll defer to Caitlin on that one, if that's okay.
Yes, that's a great question. Hopefully everyone can hear me okay. So in Vermont, we see, probably 2 or 3 youth who die by suicide each year. If the youth interacted with any of these data sets listed here on the screen, then we would have information for them there. Is there anything specific at schools that you guys are interested in knowing?
Well, I think about, recently there was a high school student who died by suicide. So let's say that high school student didn't interact with anything here. Mm-hmm. So could you include, if you know the youth for the past 2 years, where they went to school, reach out to the schools to say, what was happening? What do you know was happening in that youth's life at this point in time? I think we could be missing quite a bit without having that school connection.
So with youth, they would be reflected in the Vermont Violent Death Reporting System. So that data system collects information from law enforcement reports and medical examiners, so people that are part of the death scene investigation. So we would have information that the family members report to law enforcement or medical examiners for circumstances around suicide. But yeah, there could be missing information for those youth.
So would it be possible to add that as a connection here? I don't know how far along you all are in your project.
So at this point, because we need to set up data use agreements with each agency or partner, and that process takes usually 6 months, and we're planning to publish this September, we probably can include them for this iteration of the project, but future iterations of the project. Another thing that I do want to touch on is, in Vermont, we do have small numbers, and we also care very deeply about keeping people's information private and confidential. And so with that, and especially with data, we have to set suppression rules. So if we're looking at an analysis specific to youth, and we only have, 2 to 3 youth a year that die, we really have to look at youth suicide deaths over a number of years to be able to look at any sort of trends or make any sort of conclusions. So for this project, we're starting out with an overall sample size, we're looking at suicide deaths from 2020 and 2021. That's a total number of 246. But yeah, so in the future, if there's a strong interest in understanding youth suicide circumstances and interactions, we could, combine data years and partner with the education.
Okay. So Representative Black just reminded me of something. So the Child Fatality Review Team reviews all youth deaths. So would you be connected at them at all with this data linkage project?
So the Child Fatality Review Team doesn't review all deaths necessarily, but they review a subset of deaths. So we, they produce a report every year, and I think they published their report this year with some of their main findings. I reached out to them to see if we could get data for our project, and I think there was like some rules, and I think like their data stays within their team and can't be shared with others.
Oh, well, maybe we can change that. All right, we'll come back to that.
Yeah, and I do know that for the report, I did look through the latest Child Fatality Review Board report, and they did look at youth suicide deaths and develop some recommendations for improved suicide prevention programming based on their review of youth suicide deaths.
Okay, so you would at least be able to take the report and factor it into what you're finding.
Absolutely, yeah.
All right. Thank you, Caitlin. Anyone have questions for Nick, Art?
I have a question, and maybe you may know Lori or Alyssa or the guests here. Who's the final arbiter of whether a death is suicide? Where does the stat come from? Does it come from the coroner's office? Is it on the death certificate? Where is that?
I'm going to look to Nick or Allison. Nick?
Caitlin, do you want to take that? You probably are the best, most eloquent to describe it.
So the person completing the death certificate is the person who deems the manner of death. Most oftentimes in the state of Vermont, it is the office of the chief medical examiner who determines that the death is in fact suicide. Suicide deaths, that information is found on the individual's death certificate.
Okay, I'm going to follow up with a question that people don't throw rotten stuff at me. Older folks who at end of life who choose to end their life with suicide, are they in that mix too?
In the death, through our,
On their certificate, I mean, would the coroner say, well, they took a medicine, they died of suicide and they're part of the stat? I'm just wondering if they are part of the statistic, that's all.
So if you're talking about deaths with dignity,
yes.
Those are not included as suicides.
They are not included.
They are not
Okay.
included
All right. Thank
as
you.
a suicide death.
Yep. Thank you.
So, on all of this that you're doing, the 5 goals you laid out, and then obviously the goals you're going to do with the grant money and the suicide data linkage project, who has ownership? I think that's one of the things I struggle with when we talk about suicide prevention in the state. And when I look at the list of community partners that Chris put together in his presentation, it's like everyone has a piece, but where is it all getting funneled through?
Yeah, Madam Chair, that's a great question. And I think that was one of the key takeaways from this post-vention assessment is that there isn't a place where post-vention sits, where Vermont comes together and as a state manages and proactively improves services. It's really been a lot of people are doing a lot of great work, but it's been very grassroots. It's been pretty varied depending on where it is in the state. And so I think when we set out to start looking at post-vention, we kind of realized pretty quickly that we didn't know the state of the state in terms of post-vention services. And so our goal with this post-vention work is actually to pull together all of those key people and hopefully use the strategic plan to sort of have all of us working together in the same respect. But where it sort of lives on an ongoing basis, I think that's a really important question, and making sure that there is someone in a leadership position who is continually making sure that we focus on improving post-vention care is really, really important. AFSP has done amazing work, and they're an important partner. And I think the state also in its own way needs to provide leadership and have some level of responsibility that, sort of we continue to prioritize this as an important issue.
Okay, thank you. Daisy?
As an add-on to that, can you speak to what sort of integration that plan might have with the one, I think it's actually called the platform, the Suicide Prevention Platform that the Suicide Prevention Coalition did several years ago. And I know CHL, and when Joe Ellen was president or CEO, had talked about updating that. I don't know if Allison might be able to talk to that point about integration. Is that possible with the prevention platform and the post-vention platform?
Yeah, I mean, we've talked about right now we're in discussions about sort of the semantics, right? What's the platform, strategic plan? And we're working with really our national partners. So we've connected, when Chris came on board, connected him with it's SPRC, right? The Suicide Prevention Resource Center, who's kind of helping us say, is it really a platform that you need, or do you need a strategic action plan? Mm-hmm. And so I don't want to speak for you. I don't know if you want to talk about where that's at.
Yeah, and Nick knows as well too. So CHL is working on updating that platform this year.
So can we just stop right there? So you have you have AFSP, which is what? American Foundation for Suicide Prevention. You have CHL, which is Center for Health and Learning.
Correct.
And then you have the Vermont Suicide
Prevention
Resource
Center.
Center. So how do those three connect? Or do they not?
They connect through suicide prevention.
But they're three separate entities?
Yeah.
Okay. And we, as a state, work with all three.
Yeah, so the state, the Department of Mental Health has a public-private partnership with the Center for Health and Learning.
Okay.
So that group established the Vermont Suicide Prevention Center, which is really, we call it a center. It's really their website and kind of that's what we're deeming this partnership. And that partnership sponsors a coalition. And that coalition has a lot of those ingredients, you just named and more.
Okay.
So I would say that's the coalition is the network by which we go in and we say, AFSP's at the table, what are your recommendations, what are you working on? The state comes in and presents on what our priorities are, and that coalition says, oh, hey, we're doing this over here. So that's a quarterly meeting, but we don't have this otherwise formal relationship, say with AFSP. The formal relationship is with CHL, and that's what we're calling our public-private partnership. And other states have promoted that because there's a lot you can do with a non-state entity
Right.
that's helpful to have a partnership with.
Right. So, okay, so I get all that, but I just need one more, I need a little bit more help on the connection. So Community Health and Learning created the Vermont Suicide Prevention Center, and they created a coalition? Where's the coalition come in?
So in our grant to the Center for Health and Learning, they're required to facilitate a coalition.
Okay, gotcha.
And that coalition's been going on for years and years.
Okay,
And then Allison also mentioned the Suicide Prevention Resource Center, which is more of it's a national organization that provides technical assistance to states. So we are working with them to kind of figure out how we want to update the platform, and using their knowledge and expertise that they have throughout. We work with a regional manager on that. So she's providing us assistance and knowledge on how to do that and how to move us forward towards a strategic plan.
okay, so let's go back to that. Sorry, and your question, I didn't mean to overtake.
And just to kind of close the loop on all of that, those projects are all funded historically through mental health block grants. And then this year we funded them potentially, they're in the budget right now, as global commitment investment dollars.
Okay.
And that's a shift new for this year.
Okay,
But they've been grant projects up until now.
And I think where you're going in both Daisy's question and your clarifiers are, we're in this weird position, right, where Center for Health and Learning, through our grants to them, has led a lot of this work, and then there's been grassroots things everywhere. And now we're in a position where we have a state position. So what is the difference between having a CHL platform versus a state strategic plan?
right.
And I can't make it any less messy for you. But
Okay, that-
yeah, those are the conversations
Yeah.
that we're having.
Okay, so let's go back to your strategic plan. Sorry, keep going away from that, and it's really important to hear about.
Yeah, I think really at this point is I want to see the platform updated, right? It hasn't been updated since 2015. A lot's changed since then. Now, how do we move that platform and what do we gather from that platform and the different surveys that we've done, the different needs assessments that we've done through the grants at VDH? How do we compile all of this information and knowledge and move that forward now that I'm in this position and that this position is here and established? How do we move forward as a state? How can we ask SPRC, Suicide Prevention Resource Center, to help us move us as a state forward to a strategic plan, get that together. And, you know, for instance, our area manager has really pushed us to establish a strategic plan. She wants us to have one. And so she's providing a lot of emphasis on that. And so my intent is to connect with the state of Colorado. They have an Office of Suicide Prevention, and they have a really effective strategic plan. So my intention is to reach out to them and gather from them what their process is for compiling that strategic plan. What were the elements that they have in there? And how do we adopt that for the state of Vermont, knowing that they're at step 10
Right.
and we're
Really just
maybe at
starting.
step 1.
Right.
So how can we continue to build on the momentum that we have with the assistance from them and also SPRC? And that's ongoing support through SPRC as well.
And so Nick also used the terminology strategic plan. So is this the same strategic plan or is it, we're all working together, or Nick, do you have a different idea? Project.
So we're absolutely working together, and this is we developed this postvention assessment before Chris had been hired, so he's still getting up to speed on it. But the plan all along has been for all of this postvention work to be, once there is a state sort of broad suicide prevention strategic plan, all of our plans for postvention improvement would be embedded and included in that broader plan. So this is really just, we're doing the important work right now to figure out what should we do for postvention, and then we'll add that into our broad state plan when it gets created. So it absolutely will be integrated.
Inez, thank you for that. Inez, and you may not know this yet, when you say this broader state plan and you're working with the Strategic Prevention Resource Center, it would be a plan owned by the state, not necessarily one of our partners, although we could use a partner to help facilitate what we as a state want to do. Okay, I see everyone shaking their heads.
Does that assist in kind of clarifying
Yes.
the players and
It does for me.
the activities?
Do other people have questions? Sorry, I've just been rattling on.
No, very helpful. Thank you. Yeah.
Art?
No, it is very helpful. But I want to know one thing. Your position is new, correct?
Yeah.
Okay.
And I think that's a really good point, Art. So
Yes.
so just as a reminder, this committee last session passed legislation signed by the governor to hire, are you a director of suicide prevention?
Yes.
Yeah.
And you started in,
January 6th of this year.
right. So, so we have to give Chris, very impressive. Doesn't know, right? So I think it's really important for us to remember that, like, that's what we did, right? So we put this person in place, which is excellent. And now we need to make sure, one, we're stating what we want our policy to be, but also giving Chris the time with everyone else to move forward on things
Why
like
I asked the
that.
question.
Strategic, that was a great question, strategic plan. So that's helpful.
And in terms of also getting that strategic plan together too, I think that's where my learning from Colorado about what the process is in terms of their timeline, and to compile all this. I mean, they probably were able to work off another strategic plan that they had already established.
Right.
We're starting not from square one necessarily, because we have a lot of different surveys and needs assessments that we've already compiled, but how do we get that all into one living document?
Right.
Right, and it doesn't happen overnight.
And the resources to put it in effect. I mean, that's,
Exactly.
that's key too. We can put anything in a document, but we don't have the resources to move it forward.
Yeah.
So this was postvention. I think we did great. Nick, go ahead.
Yeah, sorry, just a couple of loose ends that I forgot to mention, just in terms of identified needs that kind of got lost in the weeds. But we talked a little bit about the role of the chief medical examiner and the assistant medical examiners who are often on site. One of the other needs that they have said is, if they had social workers who were embedded or connected to that program, it actually would allow them to both do a better job providing support to people who are directly on site when a suicide death occurs, as well as do a better job collecting information about the circumstances of the death. And so I had forgotten to mention that when I was talking about the assistant medical examiners. And then lastly, just, I know the committee was interested in best practices in other states. And, I don't know if this would work in Vermont because we are smaller, but some states actually have dedicated postvention teams that that's the only job. And they actually go, around the state or to different communities and are specialized in providing postvention response. So just sort of another example of how some states prioritize and support having dedicated support for postvention versus asking a program like a crisis team to do postvention among many things that they do.
All right, thank you. Thank you for that. All right, is everyone okay with taking a break?
Yeah.
Okay, let's take, we'll be back at, you have a question?
No.
Okay, let's come back at 1:45. I think we still have Nick, Caitlin, I don't know if we still have you as well, but we'll come back on, not 1:45, sorry, 2:45, and we'll pick up on prevention, crisis line.